Welcome to Lincoln American University.
You can see the accomplishments and the qualifications of Professor Manindra. Professor Manindra is he's a professor in the Department of Surgery and is practicing surgeon in Safdarjung Hospital, and he takes classes for the students for Vardhaman Medical College here in Delhi. He has over 20 years of teaching experience in various government medical colleges, both in India and abroad. He is a very well sought after teacher, and we all know his skills. He is also a renowned person in surgery, especially in laparoscopic surgery and in bariatric surgery. He has got fellowship from the Indian Gastroenterological Endoscopic Surgeons, from under whom he underwent the training. So you can see he has got a lot of fellowships, lot of qualification, and above all, he is himself a clinical surgeon. More than this, he is a wonderful human being. He is very much interested in the development and growth of students. He takes personal interest, and you can imagine his interest that every day of the week is in the hospital. And today being a Sunday and a rest day for him, but he agreed to our proposition of having this session on a Sunday morning. And I know that many of you would feel that your Sunday has been interfered with, but I have told him, don't worry, my students are very good students, and they are very much hunger. They have a lot of hunger for knowledge. And so Dr. Manindra, I can assure you that you will not find anybody who will be having lack of response to whatever you tell them. One thing I must tell all of you, that please you can ask him questions. Try not to interrupt the presentation, but in case something has not been clear to you, then please only one by one ask questions. Don't ask questions in a jiffy. Routine questions can be put in the chat box. So from there we can read out the question, he can answer you. Otherwise, if you feel he has not understood something, in that eventuality, you can ask him before he progresses to the next point. The subject on which he is going to talk is related to trauma. And trauma is of various types, as you all know. There are medical traumas, surgical traumas, there are, emotional traumas, there are physical traumas, there are spiritual traumas, there are endogenous traumas, there are exogenous trauma. So trauma can be classified into so many different disciplines. Trauma itself is a discipline and a subject. But he is going to cover primarily surgical trauma with you, and he will discuss various aspects of surgical trauma with you. For other aspects of trauma, we will get other faculty members to discuss the other aspects of trauma with you. I know you have got other faculty with you who have been teaching you various types of traumas, but the present deliberation will be only on surgical trauma. I'm not going to talk anything about trauma because that will take away the gist of what he is going to tell you. So he will tell you everything about trauma today, and subsequently he will take you forwards as subsequently take more classes for you pertaining to the impact of trauma and other aspects of trauma which he cannot cover today. So I think we are given sufficient time. We are at least 10 minutes beyond our scheduled time. Arun, please take the attendance and note it down, that how many have come and how many have not come, so that we can inform the president and we can inform the dean of LAU, so that he can simply tell them that so many students have not turned up today. I think not very many are absent. It's only about 4 or 5 who appear to be absent from what I see from here. So I think Professor Rana, I must thank you. Professor Manindra, I must thank you from the bottom of our heart for having given us this privilege of listening to you today. And especially my students will be very, very happy when you address them. And we will take on the questions as and when they ask the questions. And none of you must hesitate. Please put down your question in the chat box if you think that you have really not understood something before you go to the next aspect. So you can also, one by one only, ask the question in between, but try not to interrupt unnecessarily. Okay. Thank you very much, all of you. I think Professor Maninder, all yours. Please take my students to the journey of trauma.
Thank you very much, sir. I'm very thankful to you. You have given me an opportunity to prove my expertise in this field. So straightway, I would like to go to class. I think everybody is ready. Good morning, everyone.
Good morning, sir.
Good morning, sir.
So I'm Dr. Manindra. Straightway, I'm coming to the topic trauma. I'll start from trauma. First of all, what is trauma? Introduction of trauma. Trauma or injury is defined as the cellular disruption caused by an exchange with environmental energy that is beyond the body's resilience, which is compounded by cell death due to ischemia oblique perfusion. First of all, you have to know what is trauma or injury. Then after, you'll be able to diagnose a case of trauma, type of injury, level of injury. So once again, I would like to define it. Trauma or injury is defined as the cellular disruption caused by an exchange with environmental energy that is beyond the body's resilience, which is compounded by cell death due to ischemia or perfusion. Now you see through this figure, distribution of global injury mortality by cause. So death due to trauma is almost all 25%. That is mainly due to road traffic injuries. And next highest rate is 17%. That is poisoning. And 16% that is fires. So that is because of burn. So I would like to focus upon road traffic injuries. Next slide. Goals. Safe and reliable methods for immediate treatment for the injured patients and the basic knowledge necessary for. So unless until you don't know how to assess the patient and what type of injury, you can't treat the patient at all. So within few minutes, within few seconds to minutes, you have to start the treatment of the patient. Suppose a patient comes to you of RTA, road traffic accident, you have to assess the patient first. Assessment with accuracy. So a patient is in ER room, emergency room, and you are sitting there, you have to first assess the patient and his condition with rapidly and accurately, with rapid kind of your clinical skills and with accuracy. And you have to start within 10 seconds, within 10 seconds. So I'll define it later on. And second point is resuscitate and stabilize patients according to priority, which patient needs more rigorous or immediate treatment, immediate attention. That depends on your skills and your assessment. Similarly, you have to determine whether a patient needs exceeds a facility's resources and or a doctor's capabilities. Suppose you are providing all kind of medical support in ER room and patient needs more support and more expertise help. So you have, in that situation, you have to refer the patient or you have to call the expert doctors in that room. So another point is arrange appropriately for a patient's inter-hospital or intra-hospital transfer in the condition that patient whether really needs transfer or not. That is up to you. Or I mean to say that depends on the treating doctor who is sitting in the ER room. ER room means emergency and casualty room. ER room. So in which condition, when patient should be transferred and who will transfer the patient, who will take decision to transfer the patient, and what circumstances and how patient will be transferred to from primary center to tertiary center or secondary center. Similarly, you have to ensure that optimal care is provided and that the level of care does not deteriorate at any point during the evaluation, resuscitation, or transfer process. So this is main important. Mainly this is 5 component and depends on your skill. So the objective of this goal, this assessment, you have to first know about the need for trauma center and systems. So before going to another topic, I would like to first define this need for trauma center. Why do we need trauma centers in this country? Trauma center and systems, systemic systems. So trauma remains the most common cause of death for individuals between the ages of 1 to 44 years and is the third most common cause of death regardless of age. Unintentional injuries account for over 110,000 deaths per year, with motor vehicle collisions accounting for 40%. Homicides, suicides, and other causes are responsible for another 50,000 deaths each year. Injury related to medical expenditure are estimated to be $117 billion each year in the United States. The aggregate lifetime cost for all injured patients is estimated to be in excess of 260 trillion. You know, such an huge amount is required for the treatment of trauma victims. That is why we need trauma center and its systems. For these reasons, trauma must be considered a major public health issue. Therefore, the American College of Surgeons Committee on Trauma addresses this issue by assisting in the development of trauma centers and systems. Objectives of emergency care for trauma patients. So I would like to discuss with you what are the objectives of emergency care. Whenever accident occurs or trauma occurs, there is a golden hour. That is very, very vital time to save a patient. The concept of golden hour emphasizes the urgency necessary for successful treatment of injured patient. Therefore, the American College of Surgeons Committee on Trauma recommends ATLS, Advanced Trauma Life Support course for all doctors. You have to mandatory or compulsory, you have to go under this training after completion your MBBS or even during your internship or residency period. It is just as relevant to doctors in a large teaching facility in North America or Europe as it is in a developing countries with least facilities and infrastructures. So my purpose of imparting this training, theoretical training, practical will be given in the hospital only, bedside. But this is theoretical training and you have to gain knowledge from this slides. So all doctors should be able to demonstrate the concepts and principles of primary and secondary patient assessments. The concepts of principal and primary and secondary. Concepts, what are the principles of primary and secondary patient assessment? How do you assess a patient? Right now, at this point, all of you are not aware what are the concepts. So my aim is to give you certain points, clues, how to assess the patient during primary survey and during the secondary survey. So another point is to establish management priorities in a trauma situation. So how will you prioritize trauma victims? Suppose a lot of victims are there. So how will you prioritize among these? Which one needs more aggressive treatment and which one can wait for some time? And to initiate primary and secondary management necessary within the golden hour for the emergency management of acute life-threatening condition. Golden hour, that is first 1 hour. So that is the main important point. When accident occurs, you have to start treatment within 1 hour. And you have to not only treat the patient, you have to stabilize the patient within first 1 hour or within the golden hour. The following skills that are often required in the initial assessment and treatment of patients with multiple injuries in a given simulated clinical and surgical skills practicum. So unless and until you are not so much skilled, then you cannot treat the patient within the golden hour. So my purpose is to train you also. Primary and secondary assessment of a patient with multiple injuries. So primary and secondary assessment, that is primary survey and secondary survey. Primary survey I'll define you later on in this topic today only. What is primary survey and what is secondary assessment? So establishment of a patient airway, initiation of 1 and 2 persons ventilation. So first of all, primary survey that includes A, B, C, D, E. A for airway maintenance. So first of all, we have to put an airway for the respiration, to maintain the respiration of the victim, or for ventilation of the injured patient. That is, if patient is not going to breathe, then we have to put orotracheal intubation on adult and infant also. Pulse oximetry, whether oxygen saturation of blood is adequate or not, and whether patient is in hypoxia or not, we have to assess through pulse oximetry. And carbon dioxide detection is exhaled gas. That is also. Next point is cricothyroidotomy. If patient, after putting this orotracheal intubation, patient is not able to breathe properly, then we have to do cricothyroidotomy and treatment of a patient in shock, particularly recognition of life-threatening hemorrhage. Cricothyroidotomy is a small operative procedure that is performed on the anterior neck of the patient. So I'll discuss it later on also. Venous and intraosseous access. How will you A, B, C, A for airway, B for breathing, and C for cricothyroidotomy is for breathing. If you want to establish breathing properly, you have to do cricothyroidotomy also. So C, venous and intraosseous access. So patient is in shock. If a patient is in shock, so you have to give fluids through veins or through intraosseous access in a child. Next point, pleural decompression via needle thoracentesis and chest tube insertion. Pleural decompression via needle thoracentesis and chest tube insertion. If a patient during accident or after accident develops pneumothorax, hemothorax, or hemopneumothorax, then immediately we have to perform chest decompression, pleural decompression, or needle thoracentesis, or intercostal. We have to put intercostal drainage tube also. I think, is it clear to you? To identify cardiac tamponade and the procedure of pericardiocentesis. So if there is cardiac injury, then we have to perform pericardiocentesis. Pericardiocentesis, I'll also explain later on. Clinical and radiographic identification of thoracic injuries. So how will you establish that this patient is having thoracic injuries, chest injuries? Then you have to perform X-ray AP view, X-ray P view, and X-ray AP view. Use of peritoneal lavage, ultrasound, and computed tomography in abdominal evaluation. So in case we are not sure whether patient is suffering from abdominal injury or not, we have to do peritoneal lavage. Nowadays, peritoneal lavage is obsolete. So ultrasound is very useful, non-invasive, and investigation of choice also. So ultrasound is ultrasound whole abdomen. It's very useful, and computed tomography is also very useful in case of hemoperitoneum or splenic or solid mass injury. Computed tomography will rule out immediately then and there. So next point is evaluation and treatment of a patient with brain injury, including the use of Glasgow Coma scale, that is also called GCS score, and CT of the brain. Glasgow Coma scale, GCS score, is normal score is 15. If it is less than 13, it indicates that patient is having head injury also. So we have to rule out through CT scan. Assessment of head and facial trauma by physical examination. Protection of the spinal cord and radiographic and clinical evaluation of spine injuries. So we have to protect the patient from cervical injury, spinal injury during transfer or during initial treatment also. So there is some spine board mean for this trauma patient only. There is cervical collar to stabilize the cervical spine of an injured patient. Next point, musculoskeletal trauma assessment and management. Whether patient is having any muscular injury or bony injury like long bone fracture of thigh or both bone fracture of lower limb or upper limb. So we have to look for that also. Estimation of the size and depth of the burn injury and volume resuscitation. So we have to assess the patient of a burn injury, the size and depth of the burn, whether it is superficial burn or deep burn, and the volume resuscitation. How will you replace the volume of a victim? Volume of this in a shock patient. So, and recognition of a special problems of injury in infants, elderly, and the pregnant women also. Understanding of the principles of disaster management. These are the funda you have to understand, and I'll explain everything. This is trimodal death distribution. So number of deaths, immediate, this is within first hour. At the bottom horizontal line, this is hours and weeks. So death, red line, vertical red line, that is going upward, number of deaths. This is within first hours. Then it gradually, it comes down. It is coming down. Almost all flatten within 2 hours. So first hour is very crucial phase. Then second hour, then gradually third, fourth, and then days and weeks. So if injury occurs within first hour, trimodal death distribution of death implies that death due to injury occurs in one of the 3 periods or peaks. The first peak occurs within seconds to minutes of injury. So I'm going to define you this first golden hours. So it is divided into 3 peaks. The first peak occurs within seconds to minutes of injury. During this early period, deaths generally result from apnea due to severe brain or high spinal cord injury or rupture of the heart, aorta, or other large blood vessels. That is why it is recommended A, B, C, D, E. A for airway. So you have to protect from apnea, you have to maintain the airway. You have cricothyroidectomy, you have to take care of B, that is breathing. And for blood vessels or fluid loss or blood loss, you have to care for C, that is circulation. You have to maintain the proper circulation and volume also. Very few of these patients can be saved because of the severity of their injuries. Only prevention can significantly reduce this peak of trauma-related deaths. So prevention is better than cure. You can, if you want to save the patient or the victims, you have to take a precautionary measure. At that point of time or at the time of injury, it has been recommended by the various committee that there will be a pre-technician trauma team. So at the time of injury or after the injury, they can take care of the victim before arriving to the ER emergency room. And second peak occurs within minutes to several hours following injury. Deaths that occur during this period are usually due to subdural and epidural hematoma. This is brain injury, epidural hematoma, and hemopneumothorax, ruptured spleen, that is because of a splenic injury, laceration of liver, pelvic fractures. Usually in a severe case of injury, pelvic brim fracture occurs, and that causes a rupture of the urethra. Patient cannot pass urine, and there will be severe bleeding in the bladder also, and or multiple other injuries associated with significant blood loss. The golden hour of care after injury is characterized by the need for rapid assessment and resuscitation. Earlier I was discussing the need for rapid assessment and resuscitation, which are the fundamental principles of advanced trauma life support. And the third peak, which occurs several days to weeks after the initial injury, is most often due to sepsis and multiple organ system dysfunction. So we have to take care of that also. History of advanced trauma care. Why do we need a advanced trauma care center? If we look backward during the 80s, like a tragedy occurred in February 1976 with an orthopedic surgeon who was piloting his plane and crashed in a rural Nebraska cornfield. The surgeon sustained serious injuries. 3 of his children sustained critical injuries, and 1 child sustained minor injuries. His wife was killed instantly. So this is very sad. And the care that he and his family subsequently received was inadequate by the day's standards. So at that time, trauma care was not appropriate. So they could not save his wife and his children also. So a group of private practice surgeons and doctors in Nebraska, the Lincoln Medical Education Foundation and the Lincoln Area Mobile Heart Team nurses, with the help of University of Nebraska Medical Center, the Nebraska State Committee on Trauma of the American College of Surgeons, and the Southeast Nebraska Emergency Medical Services identified the need for training in advanced trauma life support. A combined educational format for lectures, life-saving skills demonstration, and practical laboratory experiences formed the first prototype ATLS course for doctors. That is why advanced trauma care is required nowadays. If you want a patient's life, you have to be much more aware how to treat a patient, quick assessment, treatment, and stabilize the patient. And this is the purpose to train you for this trauma care. For patients with previously undiagnosed medical condition. So concept of trauma care, if a patient comes to you and patient is having some undiagnosed medical problem, so you have to, through history or patient's relative gives you proper history, then only you can be able to assess the patient and start treating properly. An extensive history including past medical history. Suppose patient is having diabetes mellitus or patient is having like bronchial asthma and he met with an accident and people took him to the hospital and you are sitting there and you don't know that patient is also having a bronchial asthma or diabetes mellitus. So you may not be able to treat the patient properly there will be something missing and you will lose the patient. So you have to go through proper history also from patient if he is aware or conscious, otherwise his relatives, his or her relatives, or the person who took the patient to the ER. A physical examination is starting at the top of the head and progressing down the body. The development of a differential diagnosis and a list of adjuncts to confirm the diagnosis. Although this approach was adequate for patients with a diabetes mellitus and many acute surgical illness, it did not satisfy the need of patients suffering life-threatening injuries. Therefore, the approach required change. So, what change required? The result was the development of ABCD approach to evaluate and treat the injured patient. So, now I'm going to explain you what is ABCDE. It is recommended worldwide. So, airway with cervical spine protection. So, first of all, you have to maintain airway with cervical spine protection. There is a cervical collar. You have to apply to the victim or to the injured patient to his neck, his or her neck. That will stabilize the cervical spine and patient may be able to breathe properly. You have to airway. You have to put an airway like that is tongue depressor, like something. It's a made of plastic thing that maintains the airway. Breathing. If for breathing, you have to assess patient's condition, like is there any pneumothorax, hemothorax, or pneumohemothorax. And for circulation, you have to put a wide bore needle, 2 wide bore needle in both the upper arm. If upper arm is not visible for this intravenous fluid therapy, then you have to look for another option in the lower extremity also. So circulation, stop the bleeding. You have to give some medicines also to stop the bleeding. What medicine? That will be discussed later on. D for disability or neurologic status. So disability, if there is long bone fracture or cervical injury or spinal injury, there will be disability or neurological, like neurogenic bladder. It can cause neurogenic bladder. Patient cannot or may not be able to pass urine also. That is called neurogenic bladder. And E for exposure. You have to undress the patient and environment temperature control. Suppose patient is a case of drowning, you have to undress the patient. If patient is a case of chemical burn, you have to undress the patient, because subdermal absorption may take place. In a case of insecticide, suppose your patient is exposed to organophosphorus poisoning. Organophosphorus is a compound that is being used in agriculture, in farming also, and that is poisonous. So it is, if a patient comes in contact with that organophosphorus through his or her skin, it will absorb through the skin and patient may go into shock also. Now I'm going to start initial assessment and management. Initial assessment and management. How will you initially assess the patient and how will you manage? First of all, assess the patient, then manage the patient. Pre-hospital phase, that is pre-hospital trauma technician. That will be taken care of by the trauma technician. This is a separate course which is being taught by the faculty in our hospital or in different hospitals. There is a separate course for the technician. They have to know that how will you take care of patients in the field. So this is called pre-hospital phase.
Excuse me, sir.
Yes.
Is this similar to paramedics?
Yeah. No, not
Okay.
exactly. Not exactly similar to paramedics, but this is a separate course. This is called pre-hospital trauma technician, trained for this accident victims only. I'll explain you step by step. So don't worry.
Okay,
The-
sir.
This
Okay,
is
sir.
pre-hospital trauma phase. During the pre-hospital phase, emphasis should be placed on airway maintenance. Suppose you are not there in the field or on the roadside. You are sitting in the emergency room. So you cannot put an airway to the victim and patient is unable to breathe. Then there will be in the field, there will be pre-hospital trauma technician and he will be trained uh, prior to his posting in the field, how to put airway to the victim or to the injured patient, how to maintain airway, control of external bleeding event, how to put pressure on the bleeding side, and how to minimize the complication of shock also. Immobilization of the patient, like patient is having spinal injury, cervical injury, long bone fractures. So trauma technician will be able to immobilize the patient then and there only. And then he can carry the patient to the hospital also. So immobilization of the patient and immediate transport to the closest appropriate facility, preferable are verified trauma centers. There are certain identified trauma centers in the country, in every country, not in our country, in every country. So emphasis also should be placed on obtaining the reporting information needed for triage at the hospital, time of injury, event related to the injury, and patient history. The mechanisms of injury can suggest the injury of surgery as well as specific injuries for which the patient must be evaluated. The triage means, so you have to triage the patient first and about the victim before transferring to the higher center or to the hospital. Pre-trauma technician have to inform, technicians have to inform the hospital authority or doctors who are sitting in the emergency room that this patient is having such and such injury caused by such and such objects, and you have to ready for that, whether patient requires blood transfusion or fluids or immediate uh, cricothyroidotomy, whatever required, the trauma technician has to inform to the doctor first. Then he has to carry the patient or take to the patient to the ER rooms. Measure vital signs and level of consciousness. So Glasgow Coma scale. Why do we use this GCS score? GCS score is mainly for to assess the level of the consciousness of the patient. So if GCS is less than 14 and BP is systolic blood pressure less than 90 millimeter of mercury and respiratory rate less than 10 or more than 29 breaths per minute, in case of an infant less than 20, or in case of elderly or infant age more than 1 year, so patient requires hospital admission or referral to the higher center. This is flow chart, step 1. Is it visible to you, to all of you?
Yes, yes.
Is it visible? So this is step 1. Another step is step
It
2.
is visible. Don't worry, it is visible.
Right, sir. Thank you. So nice of you, sir. So if these parameters, Glasgow Coma scale is less than 14 and systolic blood pressure is less than 90, respiratory rate is less than 10, then you have to take to the patient to a trauma center. You have to carry this patient to a trauma center identified for this treatment. Step 1 and 2 attempts to identify the most seriously injured patients these patients should be transported preferentially to the highest level of care within the trauma system. If these parameters are not uh, going down, means less than 14, GCS if is more than 14 or 15, patient doesn't require any immediate admission or to the higher center. So step 2, all penetrating injuries to head, neck, torso and extremities proximal to elbow and knee, flail chest is not bony injury of chest more than 2 ribs and more than 2 side fracture, 2 different side fracture, that is called flail chest. So 2 or more proximal long bone fractures, crushed, degloved or mangled extremity. And this kind of injury, if it needs amputation proximal to wrist and ankle, pelvic fracture, open or depressed skull fracture, paralysis, then you have to take to this patient to the higher center or in tertiary center only. So step 2, if these parameters are yes, then take a trauma center. Step 1 and 2 attempts to identify the most seriously injured patients. These patients should be transported preferentially to the highest level of care within the trauma center. Highest level of care means tertiary center. If this is no, then assess the mechanism of injury and evidence of high energy impact. Then again you have to go for step 3. Falls, adults. If patient falls down from certain height, and patient is adult, suppose that he falls from more than 20 feet, 1 story is equal to 10 feet, then he'll be injured. Which type of injury you have to assess? Children more than 10 feet or 2 or 3 times the height of the child, high risk auto crash, intrusion more than 12 inches, occupant side more than 18 inches any side, ejection partial or complete from automobile, death in same passenger compartment, vehicle telemetry data consistent with high risk of injury. Vehicle telemetry data consistent with high risk of injury. Auto versus pedestrian / bicyclist thrown, run over or with significant, that is more than 20 mile per hour impact, motorcycle crash more than 20 mile per hour. Then if these parameters are yes, then transport to the closest trauma center, which depending on the trauma system needs not be the highest level trauma center. If no, assess special patient or system considerations. Then you have to proceed for step 4. Age, older adults, risk of injury, death increases after age 55 years. Children should be triaged preferentially to pediatric, capable trauma center, anticoagulation and bleeding disorders. So in that situation, you have to give anticoagulant also, and you have to control the bleedings. Bleeding disorder means patient is having hemophilia or not. Births without other trauma mechanisms tries to birth facility, with trauma mechanism tries to trauma center. Time sensitive extremity injury, end stage renal disease requiring dialysis. Pregnancy more than 20 weeks, EMS provider judgment. Then you have to proceed for contact medical control and consider transport to a trauma center or a specific resource hospital. Suppose patient is a lady and pregnant more than pregnancy is there, amenorrhea of 20 weeks, then you have to do nothing in the field, but you have to carry this patient to the higher center in the gynae department in the hospital. If no, transport according to protocol. If patient is in hospital, so this phase is called hospital phase. Advanced planning for trauma patients' arrival is essential. What is advanced planning? In the field, pre-trauma technician have to inform to the emergency room doctor that this patient is having this kind of injury. Before arrival of the patient in the trauma center or secondary or tertiary center, trauma technician has to inform the doctor about the patient's condition and type of injury. Ideally, a resuscitation area is available. So what type of resuscitation area is required? A resuscitation area is available for trauma patients, proper airway equipment, laryngoscope and tubes along with life-saving drugs tray and cannulas of different sizes like 16 gauge, 18 gauge, 20 gauge and 22 and 24 gauge should be organized, tested and placed where it is immediately accessible. Warmed intravenous crystallite solution. Remember, crystallite solution is useful in a patient of hypovolemic shock. So warm crystalline solution is required. Should be available and ready to infuse when the patient arrives in the emergency room or in the casualty room. Appropriate monitoring capabilities like ECG machine, pulse oximeter. ECG machine is electrocardiogram machine, pulse oximeter to rule out whether patient is hypoxic or not. BP instrument, blood pressure instrument, that is also called sphygmomanometer instrument. Thermometer and ABG machine, arterial blood gas analysis to rule out whether patient is in acidosis or alkalosis. This machine is ready for patient blood to rule out whether patient is suffering from acidosis or alkalosis. It is readily available in all the emergency center, and they should be immediately available. All personnel who have contact with patient must be protected from communicable diseases like hepatitis, AIDS, etc. You never know which patient is suffering from what. If patient met an accident like road traffic accident and you are there and you are touching the patient with your bare hand, you may receive some sort of infection or some problem. So it is better to handle the patient with protective measure. Triage. What is triage? Earlier we were discussing triage. Triage involves the sorting of patients based on their need for treatment and resources available to provide that treatment. Again, I am repeating this line. Triage involves the sorting of patient. Sorting of patient is which is more serious, which is less serious, which is bleeding profusely, which patient is bleeding profusely, and which patient receives only first aid, which patient requires only first aid, based on their need for treatment and resources available to provide that treatment. If you are in the field and you don't have much resources available with you, then you have to carry forward the patient to the emergency room or in the hospital. The treatment is rendered based on the ABC priorities. So what is ABC? I told you earlier. This is revised trauma score. So if you go through this trauma score on this figure, you can easily assess the patient, which patient is more serious or which patient requires triage. Suppose if a patient's breathing rate is 10 to 29, where it is variable 10 to 20 and the score is 4. If it is less than 29, the score is 3. If score is 6 to 9, then if respiratory rate is respiratory rate per minute 6 to 9, then point will be given only 2, and within 1 to 5 it will be given 1, score 1, and if there is no respiratory rate, then point will be given 0. Similarly, systolic blood pressure. Patient's blood pressure at the time of injury or just after the injury, what is his or her blood pressure or his status? Like it is systolic pressure less than 89, then patient's score is 4. If blood pressure, systolic blood pressure is in between 76 to 89, the point will be given to that patient is 3. If BP is 50 to 75, then 2. Similarly, these are the charts. You have to go through this. You can save this chart also. So this is for revised trauma score. This is pediatric trauma score. What is the weight of the patient, airway status, systolic blood pressure, level of consciousness, fracture, cutaneous, and totals. So you have to assess the patient's condition. If weight of the patient is less than 20 kg or less than 44 pounds, the point will be 2 or score will be 2. If weight of the patient of that pediatric age group is in between 10 to 20 kg or 22 to 44 pounds, then point will be awarded 1. And if weight is less than 10 kg or less than 22 pounds, then score is -1. Similarly, airway, systolic blood pressure and all. Two types of triage situations usually exist. Triage situations usually exist, two types: multiple casualties and mass casualties. In multiple casualty incidents, the number of patients and severity of their injuries do not exceed the ability of the facility to render the care. In such situations, patients with life-threatening problems and those sustaining multiple system injuries are treated first. Suppose patient's trauma score is less than whatever we have discussed in the earlier figure, is less than that, then that will be treated first. Suppose patient is in severe shock, tachypnea and tachycardia. Tachypnea means rapid breathing, rapid rate of breathing, and tachycardia, rapid rate of heartbeat. So patient will be treated first. If patient is in hypovolemic shock, so how will you decide that this patient is in hypovolemic shock? So immediately you have to put your finger on patient's radial artery or brachiocephalic or carotid artery. If there is any pulse or feeble, then patient is shock, not in severe shock. If there is no pulse, no heartbeat, that patient is in critical condition and you have to treat that patient first. The use of pre-hospital care protocols and online medical direction can facilitate and improve care initiated in the field. So if a pre-hospital technician is there and he's talking to you and you are in the emergency room and he is asking that patient is having no pulse, no BP, then doctor will give you instruction online that you have to manage accordingly, what to do, what not to do. So in mass casualty events, the number of patients and the severity of their injuries exceeds the capability of facility and staff. In such situation, the patients with greatest chance of survival and requiring the least expenditure of time, equipment, supplies, and personnel are treated first. So, in mass casualty, your resources are required very less. You can assess the patient immediately and start treating then and there only. Now I'm coming to the primary survey. Coming to the primary survey, due to shortage of the time or paucity of the time, I have to go very fast. So, what is primary survey? Simple way to assess the patient in 10 seconds. The patient's vital function must be assessed quickly and efficiently. Vital functions, what are the vital functions? Like pulse, BP, respiration, cyanosis and all. You have to assess very quickly. Management consists of a rapid primary survey resuscitation of vital functions, a more detailed secondary survey, finally the initiation of definitive care. This process, in the primary survey, this process constitutes the ABCDs of trauma care and identifies life-threatening conditions by adhering to the following sequence. First, you have to follow ABCDE: airway with cervical spine protection, breathing, circulation, stop the bleeding, disability or neurologic status, exposure, undress the patient, and environment, temperature control also. Resuscitation. How will you resuscitate the patient? Aggressive resuscitation and management of life-threatening injuries as they are identified are essential to maximize patient survival, and it follows the ABC sequence. Airway, a definitive airway, like intubation, should be established if there is any doubt about the patient's ability to maintain airway integrity. If there is any doubt in the integrity of maintenance of airway, you have to immediately put the airway or intubate the patient. Breathing in ventilation, oxygenation, the jaw thrust or chin lift maneuver may suffice as an initial intervention. So you have, in that situation, you have to lift up the chin of the patient and extend the neck of the patient. Patient will gradually start breathing. Circulation and bleeding control. A minimum of 2 large caliber intravenous catheters in upper extremity should be introduced with maximum flow rate. Maximum flow rate, that depends on the capacity of the tube. Other peripheral line cut down and central venous lines should be used. Everything will be discussed later on. Adjuncts to primary survey and resuscitation. If there is any lacuna, you have to immediately reassess primary survey. Adjuncts that are used during the primary survey and resuscitation phases include electrocardiographic monitoring, urinary catheters, nasogastric tube, that is also called Ryle's tube, other monitoring such as of ventilator rate, arterial blood gas level, pulse oximetry, and blood pressure, X-ray examination and diagnostic studies. Consider need for patient transfer. If you have given adequate treatment during your primary survey, at this point of time, you can consider for patients transfer to the higher center or to the expert doctors. During the primary survey and resuscitation phase, the evaluating doctor frequently has obtained enough information to indicate the need to transfer the patient to another facility. Prior to transfer, communication between the referring and receiving doctors is essential. Suppose you are sitting in a primary center and you think that this patient should be transferred to the higher center. Then you have, in that situation, you have to inform the doctor before referring the patient. Inform the patient, inform the doctor of the higher center that this patient is having this kind of injury and we have given such kind of treatment. Now patient is being transferred to you for your expert opinion and management. This is the protocol. And now come to the secondary survey. The secondary survey does not begin until the primary survey ABCDE is completed. Resuscitative efforts are underway and the normalization of vital function has been demonstrated. So unless until you cannot start secondary survey, you have done ABCDs. If you have done ABCDs like airway, breathing, circulation, etc., then only you start secondary survey. The secondary survey is a head-to-toe evaluation. You have to look for any injury, external or internal injury, through secondary survey. Any visual injury, if it is not visual, then you can take a help of radiological instrument or equipment like ultrasound, CT scan, or radiologist. You can take a help of radiologist also. The secondary survey is a head-to-toe evaluation of the trauma patient, that is a complete history and physical examination, including reassessment of all vital signs. During the secondary survey, a complete neurological examination is performed, including GCS score, determination. I know all of you are very much curious to know what is GCS and how it is being calculated. So I'll explain each and everything. Don't worry, just have patience. During secondary survey, complete neurological examination is performed, including GCS score determination. If it was not done during the primary survey, an X-ray are obtained if indicates by the examination. If you are unable to perform complete neurological examination, including GCS score, then you can take a help of X-ray machine, CT scan, or GCS score also. Special procedures such as specific radiographic evaluation and laboratory studies are also performed at this time. Similarly, you can take help of radiologists or from the lab technicians also, or pathologists, microbiologists. This is secondary survey. Level of consciousness, severity of head injury, assess GCS score, confirm findings, and by the help of CT scan repeated without paralyzing agents. So how will you assess level of consciousness, severity of head injury? How much head is injured? Suppose you are examining the patient and patient is not opening his eyes. He is not responding to your verbal command or your deep stimuli. You are pinching the patient. You are pinching to the skin of the patient or body surface and he is not opening or responding to your stimulation. In that situation, what will be the GCS score? That will give you a clue that what kind of and what level of injury has occurred. 8, severe head injury. If GCS score is 8, then there is severe head injury. If it is in between 9 to 12, then it's moderate head injury. If it is 13 to 15, then there is minor head injury. Then you have to go for CT scan. Pupil, type of head injury, presence of eye injury. Pupil gives you clue what type of head injury is, if it is constricted or if it is dilated or it is contralateral dilatation or constriction. That will give you clue which type of head injury it is. And you have to assess the size of pupil, shape, reactivity. Confirm finding, mass effect, diffuse brain injury, ophthalmic injury. Again, you have to take a help of CT. You have to go for CT scan, computerized tomography. It is of two types. That is plain CT or contrast. In this situation, plain CT is required. So this is a USMLE question also. In head injury, plain CT is required or contrast. Simply it's plain CT. Head injury, scalp injury, skull injury. There are two types of head injury: scalp injury, skull injury. Inspect for lacerations and skull fractures, palpable defects, whether it's a hematoma or it is depressed fracture. It's a laceration or a skull fracture. It's only X-ray skull and CT will give you whether it is a skull fracture or not. In a case of laceration, there is no requirement of CT scan. So scalp in laceration, suppose you are suspecting superficial, there is a scalp laceration and internally there is internal bleeding, then you have to go for CT scan again. And if there is depressed fracture, skull fracture, then again you have to go for CT scan. Basilar skull fracture, again go for CT scan. So maxillofacial, in these circumstances, you have to go for CT scan, facial bone X-ray, C-spine X-ray, cervical spine X-ray, angiography, duplex. These are the criteria given on the right side of the figure. Sorry, right side of the figure. Now, item to assess: spinal cord. Establish, identifies if there is cranial injury, cord injury, peripheral nerves injury. Assess motor response, pain response. Confirm findings: unilateral cranial mass effect, quadriplegia, paraplegia, nerve root injury. Then you have to go for plain spine, X-ray, CT scan, MRI. MRI is magnetic resonance imaging. Vertebral column. If there is injury of vertebral column, you have to go for column injury. You have to think for column injury, vertebral instability, nerve injury. Assess verbal response to pain, lateralizing signs, palpate or tenderness, deformity. Then confirm findings. If these are the findings, then you have to confirm your finding: fracture versus dislocation with the help of plain X-ray, CT scan and MRI. Extremities: soft tissue injury, bony injury, joint abnormalities, neurovascular defects. Then you have to assess visual inspection, palpations. Confirm findings: swelling, bruising, pallor. Malalignment, pain, tenderness, crepitations absent, diminished pulses, tense muscular compartment, neuralgic deficits. Then you have to take help of specific X-ray Doppler examination, that is called color Doppler examination. Compartment pressure and angiography. Then history. Before taking history, you have to take help of, or you have to consider some mnemonic like allergies, AMPLE, AMPLE, allergies, medications currently used, P for past illness, pregnancy, L for last meal, E for events, environment related to the injury. History can be obtained from pre-hospital personnel, that is pre-hospital trauma technician or family members of the victim. Suppose patient or a victim is suffering from any kind of allergies like penicillin allergies or any drugs, and patient is coming to the emergency room and you don't know the allergic history of the patient, and you are again giving penicillin or some allergic drugs like augmentin and all. Augmentin is amoxicillin and clavulanic acid. So again patient will develop allergies. Patient will not die of that accident, but will die of this allergy and this medicine you have given. So you have to be very careful about this. To rule out following injuries: which type of injury is this? Whether it is blunt trauma, penetrating trauma or gunshot injury. Blunt trauma, that is blunt injury, thermal injury or electrical injury, hazardous environment. These are the types of injuries. You have to rule out. Physical examination. During the secondary survey, physical examination follows the sequence of head, maxillofacial structures, cervical spine and neck, chest, abdomen, perineum, rectum, vagina, musculoskeletal system, and neurologic systems. So you have to be very careful while you're examining the patient. You have to consider each and everything during your examination. Nothing should be left behind. This is the summary. Preparation for the transfer to the hospital from the site of incidence, that is triage, primary survey, resuscitation, adjuncts to primary survey and resuscitation, consider need for patient transfer, secondary survey, adjuncts to secondary survey, re-evaluation, then definitive care. These are the sequence, and this type of question can be asked in USMLE also, the sequence and the explanation also. And I'll be discussing about shock, most desired topic, next lecture, next to next lecture. If you want to know anything, if you want to ask any question, you can ask.
Thank you, Dr. Manindra. Thank you very much for your class. Now, if the students want to ask any question, you can either put in the chat box or very in a disciplined manner, you can just unmute yourself and ask the question.
If you don't want to ask right now, you can note it down and give it to me through my WhatsApp or anything, through any sources that I don't know. So I can explain you in the next lecture also. So don't think that this question answer session is over. So if you want to right now, then you can ask right now.
Anybody has questions?
Good afternoon, Doctor. Good afternoon, Dr. Rana. I have a question.
Yeah.
If a
Yes, please.
patient is not able to, if a patient is not able to breathe,
Okay.
and so and thyroidotomy is absolutely paramount. If it's absolutely necessary, should it be performed in the field, or should it be waited for the patient to come back to the hospital?
No, where are you? Yours, where are you sitting? You are sitting in the ER room or at the site of incidence?
I'm a paramedic technician. I'm a technician, and the patient is not able to breathe, and thyroidotomy is absolutely necessary. I'm
No.
on the site.
You cannot do thyroidotomy because you can infect the patient also. This cannot be done in the field then and there only. And you are the trauma technician. You are not supposed to do thyroidotomy. So you have to carry the patient to the emergency room then and there only. And before coming to the ER, you have to inform the treating doctor who is sitting there that this is I'm carrying this patient and he is not breathing. Before reaching to the ER, you have to maintain the airway. One student is asking one question, Mitali Gaurav.
Yeah.
She's saying that really good class, sir. And what the person's condition is severe. I didn't get you. I couldn't understand the question.
Now, Mitali, please come forward. What is your question?
Good.
Please come forward and say what is your question.
Good morning, sir. Actually, as Shubham said about the person condition at the site, about the airway thing. So I was asking, what if the condition is severe and the person couldn't breathe, or we can't maintain the airway till we reach the ER?
Okay, her question is,
this is the purpose of this class. You have to learn how to give oxygen or how to maintain the airway. If patient is not breathing at the site of patient is not breathing, you have to lift up the chin of the patient and extend his neck also. And you can give mouth to mouth breathing also. You can give external cardiac massage also. So you have to learn everything. how to save the patient. So patient is serious. He's in severe. His condition is very severe. But the thing is that you should be able to manage this kind of patient. So you have to put endotracheal tube. That is, pre-trauma technician will be trained how to put an endotracheal tube in a trauma victim.
Okay, sir. Thank you so much.
I'll explain everything later on in the next class. What is endotracheal tube? What are the classic methods to put in? What is thyroidotomy?
Okay, there are the questions how to assess.
Very good question. This is very interesting.
GCS
How to
score.
assess GCS score in pediatric patients?
Yes.
So GCS score is the same. So Glasgow Coma score. That is easy to remember. ECS. EVM, sorry, that's EVM. Eye opening, verbal command, and this is motor response. So you have to read GCS thoroughly, then I'll explain you. If you don't read GCS score, I may not be able to explain you. Total score is 15. GCS Glasgow Coma score is 15. So in the next class, I'll teach you GCS also. Next.
They are understanding something, but you must understand certain terminologies that he has used in terms of primary survey, in terms of triaging, in terms of secondary survey. These things you must remember because these are important from a practical point of view. Also, you have to remember that in any trauma case, the action to be taken at site, the action during transportation, and the action at the hospital, all three types of actions have to be in continuation of each other to ensure the safety of the patient. The next thing is that you should also be able to understand your limitations so that if you are not able to understand your own limitations, the resources of your own hospital, do not keep a patient with you if you feel that the patient cannot be treated with your given resources. So the patient must be immediately referred to the next higher center. Yes, some basic fundamentals we should remember because if you delay in decision making in this case, in such trauma cases, you might, this all the difference between death, disability, relief, and sustaining life. So please remember these issues. These are very important issues. And there are various methods of doing everything, which he has already told you most of the things. But you must understand the basic concept of what he is trying to tell you. That in the primary survey, it is your A, B, C, D, E that is important. And if you understand airway means your airway should never be obstructed. You have to relieve the obstruction of the airway, which can only be done by a chin lift or a jaw thrust. That's one of the important ways of maintaining the airway by chin lift and jaw thrust. Also, you must ensure there are no blood clots or no vomiting or the tongue has not gone back. So all these things, if there is blood, if there is vomiting, and that has been responsible, you have to do some mechanical suction to take it out. So you should be aware there are mechanical suctions, there are manual suctions that are available. You should be knowing how to use them. Thereafter, you can also, if it still remains obstructed, then in that case, you have to do endotracheal intubation, for which you should be trained and you should be aware of the process of doing that endotracheal intubation. This is about the A part. That is the A part. The breathing and ventilation is mainly concerned, and you can do this once you are taught palpation and percussion and auscultation. You realize that these three are basic fundamentals. Without any support from X-rays and CT scans, you can diagnose tension pneumothorax, you can diagnose hemopneumothorax. So and you can also diagnose subcutaneous emphysema by just doing this simple test of percussion and auscultation and palpation at the site itself. So you will know whether they require thoracocentesis or where you put in a large bore cannula to ensure that the tension pneumothorax does not result in death of the patient, because tension pneumothorax causes death at a very early point of time if not managed correctly. So these are the things which you learn in the field. So breathing and ventilation and maintaining the oxygen saturation comes from such procedures. And of course, he has already told you about maintenance of circulation with bleeding control. He has told you all the details. But remember, there is something known as damage control resuscitation, DCR. Damage control resuscitation means sometimes do not unnecessarily put fluids. Excess amount of fluids may actually cause, there are some clots that have taken place which have arrested the bleeding. So excess amount of bleeding, fluids might dislodge those clots and the tamponade effect of certain things might go away. So they will start bleeding again. So be careful with all these things. This is called damage control resuscitation, which I am sure he will cover in the next class.
Damage control surgery will be discussed in the next class. And Shubham is asking one example for this severe patient. Shubham Rana is asking something. And Karishma Das is also asking something.
Yeah, I just see it's not there in my display.
Karishma Das,
Yeah, Karishma, ask your question. Shubham, ask your question, please.
Sir, can you hear me?
You are echoing, but anyway, ask your question.
Yeah, please.
Ask your question, Karishma. Unmute yourself and ask your question, or type your question in the chat box. Karishma, type your question in the chat box. Karishma is lost to us. Yeah, Karishma. We can hear you.
Yes. Yeah.
Karishma, please type your question in the chat box.
Prathamesh Mistry, he is asking for PowerPoint. Yeah, I can provide you PowerPoint, no problem.
Sir, can you hear me now?
Yes.
Sir, I wanted to ask you, sometimes what happens when a patient comes in the emergency ward, in the emergency room, sometimes you need the intervention of doctors from more specialized disciplines.
Okay.
So the doctors in the ERs, how do they decide when and how to call, a specialized doctor to have a look at the patient? At
Okay.
what point?
Okay, this is very good question. That is why we are going to train you to handle with this kind of patients. So if you are sitting in the casualty room, you have to decide which type of doctor is required in which circumstances. Suppose patient is having abdominal injury, splenic injury, intraperitoneal injury, then surgeon will be required. General surgeon will be required. If patient is having head injury, neurosurgeon will be required. Similarly, so I can give you so much examples. Then this is the part of training. It is better. Dr. Kapoor will explain you everything. Is much senior than me.
It's all right. Okay, Karishma. Karishma, what happens when a patient comes in the emergency? You are required to provide first aid and resuscitation to ensure that he is stabilized. After that, when you do the secondary survey and you find out what are the types of injury, if he has got head injury, you know you are not competent to deal with a head injury case. So therefore, you have to call a neurosurgeon. If he has got multiple fractures, you know you cannot deal with those multiple fractures. So you have to call an orthopedic surgeon. If he has got cardiac tamponade, means there is blood in the pericardium, you know you can't do anything about it. You have to call a cardiothoracic vascular surgeon. So when you do all the secondary survey, you do all your tests, your investigations, you will find out exactly what is wrong with him and whether it is within your competence or outside your competence. In the ER, your competence lies in A, B, C, D, E. And after that, whatever else you can do is a bonus. Otherwise, the patient has to be referred to that particular specialty, which can be multiple specialties you can have to work on the patient. So you have to analyze that part and then refer to the patient, refer to that particular specialist. Okay, Karishma.
Tanishk Khataukar, he is asking if a patient is having pneumothorax and thoracentesis is performed, why is it like some amount of fluid is left in pleural cavity and not fully drained? So in this situation, I would like to explain pneumothorax. Pneumo means what? Hydro means water, pneumo means what? Air in the pleural space. If a patient of chest injury and bony injury like fracture of ribs, it can cause pneumothorax or tension pneumothorax. This is a very fatal condition or situation, very serious condition. Patient may not breathe spontaneously, and lack of oxygen, cyanosis will occur, and patient can die of that situation, that injury. So if you are able to rule out clinically with the help of a stethoscope or through percussion that this patient is suffering from pneumothorax or tension pneumothorax, then it's okay. If you are not able to confirm your diagnosis, then you can take a help of X-ray technician or X-ray machine. It will clearly give you a clue that this patient is having pneumothorax. Then immediately you have to put a needle or water seal drainage. This is called water seal drainage in the second intercostal space along the mid clavicular line anteriorly. Is it clear to you? Needle aspiration, second either side from the mid-sternum, either side, left or right, depending upon the pneumothorax, side of the pneumothorax. If there is a pneumothorax of right side, then you have to put a needle on the right side in the second intercostal space and in the mid-clavicular line. Okay? And in thoracentesis, suppose you are putting intercostal drainage tube in the fifth intercostal space in the mid axillary line or anterior axillary line, then you have to withdraw fluids. There are some fluids which is left behind will be absorbed gradually. So there is no problem for a little amount of fluid in the pleural cavity. Next, Shreyas Srivastava is care given in the general hospital and care given for maxillary military veterans same, sir? Yeah, universally is the same. Whether you are going to a civil hospital or a tertiary center or a military hospital, treatment universally. If you are in USA, you are in Australia, treatment protocol is same. There is no change. Shubham, you are asking something. Please ask. Shubham Rana.
Yes, Dr. Rana, I've just asked an example of a case. You've already given plenty. I have another question that if in case the airways completely blocked, let's say someone is suffering from severe allergy, probably anaphylactic shock, and the neck is swollen or inhaled a lot of smoke in case of a fire, and the neck is completely blocked and there is no breathing. So how can we uh, reconstruct breathing there? How can we help the victim with breathing?
Okay, very good question. Very interesting and very intelligent question also. So if a patient is suffering from anaphylactic shock, then there is angioedema of the larynx. It can cause choking. In that situation, you have to, if you are able to put endotracheal tube, it's okay. If you are not able to put endotracheal tube, in that situation, you have to perform thyroidotomy. If you are not able to perform that also, simply you can make a cut along the thyroid cartilage. So can at least patient can breathe through that opening. In case of burn injury, there will be suffocation. In that situation also, you have to maintain an airway. Through endotracheal tube is available with you at that time. If you are sitting in the casualty, you have to intubate the patient and give positive pressure. You have to put the patient on ventilator also. So everything is available in the trauma center or in the hospital. So you have to know about the A, B, C, D, E. Okay, I think you got the answer of the question.
Yes, sir.
Rohit Gupta, sir, at site of incident, patient heartbeat is stopped. Then what emergency treatment is given? External cardiac massage. That is called external cardiac massage. CPR, cardiopulmonary resuscitation. CPR, you have to give CPR. CPR includes external cardiac massage, ABC management, and medications also, intravenous. So this will be discussed in the coming lecture also.
Okay.
If incident patient heartbeat is stopped, atropine sulfate can be given to this patient. Atropine sulfate, each ampoule contains 0.6 milligram of atropine sulfate. That is a drug of choice to initiate heartbeat or maintain the heartbeat. It increases the heartbeat also. And atropine sulfate is also given in a case of organophosphorus poisoning, because organophosphorus poisoning also it also causes bradycardia or asystole. So in that situation, you have to give atropine sulfate also. That will be discussed later on. Simply you know how to give CPR. CPR, cardiopulmonary resuscitation or external cardiac massage. Anyone else is caregiving is Indrish Shreyas and Rohit Gupta. Sir, at site of incident, patient heartbeat is stopped, then it has been answered. And the Rohit Gupta. Anyone else? This is my first class, so a little bit I'm also very much puzzled, and I can't see you all at once. So from next time onward, I'll be comfortable also. And I'm very thankful to Dr. Kapoor sir also. He has given me an opportunity to deliver this lecture. Thank you, sir. Thank you very much. Thanks to all of you.
Professor Manindra. Thank you very much for sparing your valuable time for our students. You know, my students are a very good lot of students. They are very, very interactive. And probably you have to visit Guyana sometime to see how energetic my students are and how much keen they are to enhance their knowledge. But we have only this opportunity at present. We shall continue our association. We are very grateful to you that please continue. They will open up more and more, and they will ask you more and more questions. So there's nothing else for me to say except thank you very much for making yourself available to us. Please tie up for your other classes so that we can give them sequence of classes at timely intervals. Yeah. And they have other classes also coming in. There are other people who are coming in to take their classes. So I have to now manage everybody together apart from their own schedule, because they have got their own online schedule. I don't want this schedule to be in conflict with their schedule. So therefore, I will keep on, troubling you. I know, and for all of you students, it is almost 10:15 at 10:15 p.m. at night.
Sir, excuse me. Last but not least, I would like to know that which book they are going through in surgery, especially in surgery. Which book they are going through?
See, the books that have been prescribed is Love and Bailey surgery only.
That is good. That is good. That is more than enough, sir.
Yeah. So that is the prescribed book for them.
Yeah.
But they have other books like shorts, and they have also got some clinical surgery also. Okay. So I think they have a sufficient amount of reading material, and they're all very clever.
Right.
They have downloaded many books from the net. Right. So you do not know exactly what all books they read. So their questions they all come prepared. If you tell them what is the next class, they will come prepared for the class.
So I'd like to take up the issues like practical, how to put endotracheal tube. What are the methods, safe methods? And suppose how to calculate GCS score and all, because there are a lot of things to be discussed.
Okay, so what we'll do is the next class will be on details of GCS score, both in adults and pediatrics.
Exactly.
Then method of resuscitation methods.
CPR, resuscitation, everything.
Okay. And you also please tell them something about damage control resuscitation, because they should be aware of this terminology: damage control resuscitation and damage control surgery.
Damage control surgery will be discussed later on, after shock.
Yeah.
After shock.
Okay.
The third class will be shock.
So next class will be, you are going to clear the concepts on Glasgow Coma scale, the various physiological parameters for triaging,
Exactly.
and endotracheal intubation.
Exactly. Thyroidotomy, endotracheal intubation, how to put venous cannula and all, number of cannulas and all, Rice tube insertion, Foley's catheter insertion.
Can it be demonstrated to them practically?
In fact, this is a bedside teaching, but
Yeah.
I'll try to demonstrate a little bit theoretically, not practically. So I don't have any patient. How can I put a Rice tube or a Foley's catheter in a patient? So
Can you borrow some mannequins from your the institution and demonstrate in a mannequin?
This will not be feasible in our hospital because we don't have much facility in our hospital. It means this type of camera and this everything.
Just see, in case you can, it will be very helpful to them.
Okay, I'll try my best. I'll try my best.
Okay. Thank you all very much.
So good night.
Thank you, Professor, for all your wonderful talk. I'm sure the students appreciated it, and we'll get the feedback. We have recorded this class for you.
Right, sir.
So we will send the link to them so they can actually see it themselves in their own free time as well. So thank you very much. Thank you, dear students. Please take care of yourself. Stay safe, and please prepare for the next class.
Right, sir. Good night, sir.
Thank you. Good night. Good night. Thank you very much.